Welcome to another episode from the Veterinary Medicine Digest. Today, we are embarking on an extensive exploration of a diagnostic phenomenon that sits at the intersection of advanced neuroimaging and clinical pathology. Our focus is a significant retrospective study titled Spinal Dural Ossifications Are Hyperintense on T1 Weighted Sequence and May Mimic Dural Lesions. To truly appreciate the gravity of this research, we must first establish a robust foundational understanding of the dura mater and the historical context of its ossification across different species. The dura mater, the outermost and most resilient of the three meningeal layers surrounding the spinal cord, serves as a critical protective barrier. However, it is subject to a variety of pathological transformations. One of the most intriguing and often misunderstood is the process of dural ossification. This condition involves the formation of mature, lamellar bone plaques within the fibrous connective tissue of the dura. Historically, much of our knowledge regarding this condition in veterinary medicine was confined to canine patients. In 1969, a seminal study by Joe Morgan investigated the incidence and distribution of spinal dural ossification in a cohort of 114 dogs. Morgan found that these ossified plaques were remarkably common, particularly in large breed dogs that were middle-aged or older. In fact, his research suggested that at least one radiopaque shadow created by a bony dural plaque could be identified in approximately 65% of the dogs studied. For decades, the prevailing clinical consensus was that these plaques were largely incidental findings, a benign consequence of aging or mechanical stress. Morgan noted that while earlier reports suggested a link to urinary retention, incontinence, or progressive paralysis, his findings indicated that in most instances, dural ossification was not productive of clinical signs. When clinical signs were present, they could often be explained more adequately by concurrent pathologies such as extreme obesity or heart disease. This established a paradigm where spinal dural ossification was viewed as a radiological curiosity rather than a primary driver of neurological dysfunction. However, this perspective began to shift as more sophisticated imaging and case reports emerged. A transformative moment occurred in 2013 when Johanna Antila and her colleagues published the first ever report of spinal dural ossification causing neurological signs in a cat. This case involved a 6-year-old ragdoll cat that presented with a 6-month history of slowly progressive gait abnormalities, eventually leading to ambulatory tetraparesis. The neuroanatomical localization pointed toward the cervical spinal cord segments between the first cervical and second thoracic vertebrae. What made this case particularly striking was the correlation between the imaging findings and the clinical state. Radiographs of the feline spine revealed a radiopaque irregular line ventrally in the vertebral canal. Magnetic resonance imaging further clarified the situation, showing an intradural extramedullary or extradural hypointensity causing significant flattening and compression of the spinal cord at the level of the 3rd to 5th cervical vertebrae. The ragdoll cat underwent surgical decompression, during which the surgeons observed that the dura mater was thicker, harder, and paler than normal. Histopathological examination confirmed the diagnosis, revealing mature fibrous connective tissue containing islands of calcified bone and cartilage. While the cat showed initial improvement, its condition eventually deteriorated due to the regrowth of ossified plaques. This feline case study was a landmark because it proved that dural ossification, while often incidental in dogs, could be a primary and devastating cause of compressive myelopathy in other species. It also highlighted the diagnostic challenge of differentiating these lesions from other space-occupying masses. This brings us to the complex problem of differential diagnosis. When a clinician identifies a lesion on the dura mater using magnetic resonance imaging, the stakes are incredibly high. One of the most feared mimics is histiocytic sarcoma. In 2015, Christopher Mariani and a team of researchers conducted a retrospective series of 19 dogs with histiocytic sarcoma involving the central nervous system. This aggressive malignancy often involves the meninges and can present with profound, diffuse enhancement after the administration of contrast medium. The imaging features of histiocytic sarcoma can be deceptively similar to other dural pathologies. In the brain, these tumors often appear as solitary extraxial masses that strongly resemble meningiomas. In the spinal cord, they can appear as intradural extramedullary or even intramedullary lesions. A critical finding in the Mariani study was that every dog sampled for cerebrospinal fluid evaluation showed pleocytosis and increased protein concentrations. Furthermore, the magnetic resonance imaging often showed brain tissue herniation or secondary syringohydromelia due to the rapidly growing nature of the tumor. The median survival time for the dogs in this cohort was a sobering 3 days. Given the vast difference in prognosis between between a benign incidental finding like dural ossification and a lethal malignancy like histiocytic sarcoma, the ability to accurately interpret imaging signals is paramount. This is where the retrospective study by Nani and colleagues, which we are diving into today, provides such essential clarity. The researchers noticed a specific trend: spinal dural ossifications were appearing hyperintense on pre-contrast T1 weighted sequences. This is a critical observation because hyperintensity on T1 weighted images is relatively rare and often indicates the presence of specific substances like fat, hemorrhage, or certain minerals. The study by Nani, conducted between January 2020 and April 2024, analyzed a cohort of 10 dogs that had undergone both computed tomography and magnetic resonance imaging. The dogs were predominantly large breeds with a median age of 10.5 years and a median weight of 31 kilograms. Computed tomography was used as the gold standard for identifying the mineralized nature of the plaques, as bone appears with high attenuation on these scans. The research team then looked at the corresponding magnetic resonance imaging signals at those exact locations. The findings were consistent and revealing. In 9 out of the 10 dogs, the ossified plaques were clearly hyperintense on pre-contrast T1 weighted sequences. On T2 weighted sequences, these same plaques appeared hypointense. When other specialized sequences were used, such as fluid attenuated inversion recovery, the plaques were hyperintense. Conversely, they appeared iso or hypointense on short tau inversion recovery sequences and showed a signal void on T2 star weighted sequences. To understand why this happens, we have to look at the physics of magnetic resonance. Tissues have specific T1 longitudinal relaxation times based on their molecular structure. A tissue appears bright or hyperintense on a T1 weighted image if it has a short longitudinal relaxation time. The researchers proposed that the high signal intensity in these ossifications depends on the architecture of microcalcifications. Calcium is a diamagnetic substance that can, in specific environments, trap water protons. This interaction slows the rotation of the water protons to a frequency near the Larmor frequency, which is the frequency at which the protons precess. This state of resonance maximizes energy transfer, thereby shortening the T1 recovery time and causing the tissue to appear bright on the image. This discovery has profound implications for clinical practice. If a radiologist or a neurologist looks only at post-contrast T1 weighted images, they might see a bright linear lesion along the dura and mistake it for a pathological process that is taking up contrast, such as an inflammatory pachymeningitis or a neoplastic dural infiltration like the histiocytic sarcoma we discussed earlier. Without comparing the post-contrast image to a pre-contrast T1 weighted sequence, the clinician might conclude that the lesion is enhancing, leading to a potential misdiagnosis and unnecessary concern or even invasive procedures. The Nani study also observed that these ossifications were distributed much more extensively than previously thought. While Joe Morgan's 1969 study suggested they were most common in the cervical and lumbar regions and primarily located ventrally, the 2026 study found them along the entire spine and involving all dural surfaces, including the dorsal and lateral aspects. This suggests that as our imaging technology becomes more sensitive, we are discovering that these changes are a more widespread feature of the aging canine spine than we once believed. In human medicine, the study of dural ossification is often linked to the ossification of the ligamentum flavum, a condition particularly prevalent in East Asian populations. Research by Bo Li, Yu Zhao, and their colleagues has explored this relationship in great detail. In humans, the progression of ligamentum flavum ossification can lead to severe thoracic spinal stenosis. When the spinal cord is subjected to chronic compression, the dura mater itself may begin to ossify and eventually fuse with the ossified ligamentum flavum to form a single, inseparable bony mass. The human studies have identified specific radiological signs of dural ossification on computed tomography scans, such as the tram-track sign, the comma sign, and the bridge sign. The tram-track sign is particularly interesting, consisting of a hyperdense bony excrescence with a hypodense center, representing the space between the ossified ligamentum flavum and the ossified dura mater. These signs are crucial for preoperative planning, as surgeons must be prepared for the high risk of cerebrospinal fluid leakage or spinal cord injury when attempting to remove these fused bony tissues. The human research also highlights the role of mechanical stress as a primary driver of the ossification process. It is hypothesized that relative movement between the ossified ligament and the compressed dura causes local inflammation and dural adhesion. This adhesion then serves as a bridge for the transport of osteogenic cytokines, such as bone morphogenetic protein 2, which triggers the transformation of dural fibroblasts into bone-forming cells. This mechanical theory aligns with the observations in veterinary medicine that ossifications are most frequent in the most movable regions of the spinal column, such as the cervical and lumbar segments. However, as the NANI study demonstrates, we must be careful not to overinterpret these findings as always being clinically significant. In their cohort of 10 dogs, the dural ossifications were considered incidental findings, and the clinical signs the dogs presented with were better explained by other imaging findings. This brings us back to the central challenge: when is a dural lesion a benign aging change, and when is it a sign of something more ominous? The retrospective study on T1 hyperintensity provides us with a powerful new tool to answer that question. By recognizing that mature bone within the dura can naturally appear bright on a pre-contrast T1 weighted image, we can avoid the trap of misidentifying it as contrast enhancement. This requires a disciplined approach to image interpretation. One must always evaluate the pre-contrast sequences with as much care as the post-contrast ones. If a lesion is already bright before the gadolinium is administered, then its brightness after contrast cannot be assumed to be enhancement. Furthermore, the comparison between computed tomography and magnetic resonance imaging remains a cornerstone of neurodiagnostics. Computed tomography excels at identifying mineralized structures, providing an unambiguous confirmation of the presence of bone or calcium. When we correlate that mineral signal with the hyperintense T1 and hyperintense T2 signals on magnetic resonance imaging, we gain a high degree of confidence that we are looking at a benign ossification rather than a malignant tumor or an acute hemorrhage. Speaking of hemorrhage, that is another critical differential that can produce a high T1 signal. As we learned from the work of Anna Zimny and her colleagues on intracranial lesions, blood in the methemoglobin phase is strongly paramagnetic and appears very bright on T1 weighted images. However, hemorrhage usually has a different clinical presentation, often being more acute in onset, and its appearance on other sequences like T2 and gradient echo will typically differ from the stable signal of an ossified plaque. In summary, the journey from Joe Morgan's first radiographic surveys in 1969 to the sophisticated magnetic resonance analyses of 2026 has drastically expanded our neurological horizon. We have moved from a simple recognition of bony plaques in old dogs to a deep understanding of the molecular physics that dictates how these plaques appear on our most advanced scanners. We have learned from the ragdoll cat that we cannot always dismiss these changes as incidental, yet we have also learned from the dogs in the NANI study that we must not mistake them for deadly cancers. This body of research underscores the importance of a meticulous, multimodal approach to veterinary neurology. It reminds us that every signal on a screen is a reflection of a complex biological process, and our job is to translate those signals into the best possible care for our patients. Whether we are dealing with the slow, predictable changes of an aging spine or the aggressive invasion of a histiocytic sarcoma, the clarity provided by these studies is our most valuable asset. As we conclude this deep dive, let us carry forward the lesson of the pre-contrast T1 sequence. It is a reminder that sometimes the most important information is already there, waiting to be seen, before we even add anything new to the system. It is a testament to the power of retrospective research and the continuous evolution of our clinical knowledge. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.